I'm going to spend a little bit of time going over pH scores in hiatal repair with transoral fundoplication, but I also want to review a little bit about how we got there. So the reason we perform transoral fundoplication, incisionless fundoplication, is because it does follow the principles of anti-reflux surgery, which were delineated in the 1990s. But an important part of that was always the hiatal hernia, felt to be at least as important as the fundoplication. Although a lot of people think of that in the surgical realm as just one procedure, it's really two procedures. We are able to meet these principles because we fix the esophagus to the fundus to the esophagus. It's constructed without a stricture because of the size of the device. The device is made to create a 2 to 4 centimeter fundoplication, and it has to be below the diaphragm. So the piece that was missing when we first started is whether or not we could get the diaphragm approximated to the esophagus, which was always part of the principles. What we do with transoral incisionless fundoplication is we're creating a Nissen type wrap that also mimics the pressure characteristics of the Nissen. So from that standpoint, it always looked like it would work real well. So when we started out, we were using, like Dr. Abadiah reviewed, the Hill criteria because we had to determine which patients would we repair the hiatus and which wouldn't. This is what normal looks like. You all are familiar with that. And again, not to review too much, but these are the different grading systems. But it's important to realize that this is kind of a spectrum, right? You go straight across. And so where in this area do we repair? And so what we started to look at was, images like this. Should we repair that? Images like this where we have a good fundoplication, but it's within a large hiatal hernia. And obviously, if we had seen that, we would have repaired it. We didn't. So when we studied TIF alone versus hiatal repair with TIF, we found that we got quite a bit better outcomes. And of course, being a surgeon, I'm getting the patients that are a little bit further down in the disease process. So it's a little self-selecting. What we want to do is be operating on them in these areas, but there's lots of patients in these areas. So the question then became is, when does the hiatal hernia become symptomatic? And so we looked at using the Hill criteria and whether we all agreed what I call a Hill 3 is what you call a Hill 3. And what we found is that we couldn't agree. Then we also looked at, well, is it the way in which we are sedating the patients? Because a lot of times we would do an endoscopy just before we started the laparoscopic repair to get a judgment. And what we found is we were actually better off when we did these endoscopies under IV sedation. So that became an important criteria. And then we were wondering about, well, sometimes we're looking at it just preoperatively and it doesn't seem like there's much there. And then we go laparoscopically. There seems like there's a lot. And we compared that and we did a publication on that. What we found is we are having difficulty. We're undergrading things in terms of when they needed repair. And so all of those are publications. And just to demonstrate, I put together this short video that shows what, this is a pretty well stretched out stomach. It looks like fairly normal. But if we don't challenge that at least a little bit, we may not identify what is actually a fairly abnormal hiatus. And if you look at this laparoscopically then, you can see that it's actually a quite large defect. And there's this fat pad that's getting in the way of your assessment. So clearly, from a surgical standpoint, we would repair every single one of these. So then the question becomes, are we accurately measuring the hiatus so that we can repair it? And when we published that study, we were using this technique. We said, okay, this is a 1 centimeter scope, and so we can kind of figure out where the hiatus is and make a measurement and say, okay, this is 1, 2, 3, 4, 5 centimeters across. Well, we came to realize that there's a lot of optical illusion to that. And so what we started doing then is measuring how big is the scope in a retroflex and would that work as a measuring device, because that's very reproducible. And so sure enough, that was the technique that was in here, is that if we are able to retroflex and bring the tip of the scope in, which you can with this, in fact, the entire omega loop is 4 centimeters. This is clearly something that we would have predicted needed to be repaired. So our current technique, which is very important in your outcomes, is to do the endoscopy under IV sedation. Be sure that you're seeing what you need to see. The retroflex tip of the scope is your measuring instrument. If you can get the tip in, it's at least 3 centimeters. That's going to lead you to expect repair. Continue to use the Hill grade, but your values to the Hill grade may change as these things are correlated. And regurgitation seems to be the symptom that we see with the larger hiatus, and bias your endoscopy towards hiatal repair, because we know when we compare that to laparoscopic surgery that we're undercalling those assignments. So you see, when we look at the studies that were done, we did a registry in 2012, and we got pretty good outcomes. But as that thinking matured among those of us that were doing TIF, we saw quite a bit of improvement in our outcomes over what was basically a 3 to 5 year period of time. And I feel that that's because we were now paying attention to the hiatus when before we really weren't. We also came out with some very good safety numbers. Our cost is comparable and quite a bit of accepted. So we're meeting a lot of the goals that we had for a procedure that basically would replace Nissen fundoplication. So that's where we were in 2017 when there was expanded labeling for the esophagus device, allowing us to talk about how to repair just prior to transoral fundoplication. What we didn't know then is what would our outcomes look like if we used that evaluation basis, if we were very careful about that, and we did the hiatal repair before. And so we were able to study that and submit this publication. So this is what it looked like. It was retrospective. We spent about 2 years looking at patients. We had sort of a diagram for who would have reflux. These patients had been on PPIs for an average of 10 years. Thin patient population. These are the things we looked at. Endoscopy, we look at Z-line, LA grade, Hill grade, axial displacement, but this greatest transverse diameter is really the number we're looking for. How wide is that hiatus? I also did manometry, HIDA, and gastric emptying for bloating and gasiness type symptoms. 97 patients over those 2 years, 30 stayed on PPI, 55 eventually had surgery with the hiatal hernia and the transoral incisionless fundoplication, a few others. What we ended up was, in a retrospective review, about 53% of those 29 patients that we could match a pre-op and post-operative study. The technique was using the retroflex hiatal assessment, doing mainly a posterior repair that was described in the Lotus trials. The TIF 2.0 technique, which we pointed out earlier, was very important. This is one generation removed device, and 7.5 millimeter fasteners in the 300-degree wrap. And these were our outcomes. All patients was a significant improvement in HRQL, RSI, and pH. As a matter of fact, normalizing those patients. No serious adverse events, no correlation to bloating, which is the reason why we don't like Nissen fundoplications, and no dysphagia. So then we went a little bit further and we looked at the patients with abnormal pH scores, and what we realized then is that initially we had 3 that it was obvious they had gapping next to the scope. This was big enough to put a tip into, and these were not intact repairs. Not because of the fundoplication. You can see that we've got nice eversion of the G junction, but because of the hiatus. And then for those that had an abnormal pH but did not look like they had anything wrong, we brought back 3 of the 4. We had one that did not come back. And 2 more had recurrent hiatal hernias 2 months later. One had sort of this fundoplication that looked like it had fallen apart. And then, of course, one with no follow-up. We did have one patient that initially had an abnormal pH. She had bad gastritis, though. We treated her, and then we brought her back again and retested her, and after treatment of her gastritis, her pH normalized. So in the end, we ended up with 21 of 22 patients with intact anatomy. 1 of those patients didn't follow up. So very good normalization of the pH in a repair that's intact, both of the fundoplication and the hiatus. Those are very good numbers. So To summarize, we're restoring normal anatomy. We're restoring the anatomy that should be there to create the reflux barrier. We show again that hiatal hernia repair is a critical part of this. If you have a dilated hiatus, it needs to be repaired. Now, what causes the hiatus to fail or fail after repair, that still needs to be studied. We haven't gotten there yet. But when those things are intact, we have very good normalization of pH. And of course, this being a retrospective study with smaller numbers, we need a randomized prospective trial, something to look at in the future. So with this data and experience, I'll make some predictions. I think that, we're looking at something that will be a new standard for reflux therapy. It's got a superior safety profile when compared to the Nissen fundoplication, and this has been well borne out. With the pH normalization at this level, it's at least equivalent disease control, if not better. Significantly, we've shown there's a reduced side effect of the main reason why we got away from Nissen fundoplications. And so now what we need to do is advance this therapy to earlier patients, right? I'm a surgeon, I see patients late in the disease process. We want to get to them earlier in the process. So should we be using PPIs more than 6 months if the patients are not responding to that therapy? If you can't get them off a PPI, haven't you proven that it's not the chemistry, it's the anatomy? And of course, you need to do the workup, but that's what I would suggest is the next step. So we start off with patients that have a hiatal defect. We repair that, but it's not really the normal end of the esophagus through the stomach. Once we do that and it heals, we get what looks like a very normal GE junction. Thank you.